Continued with the Apollo TMVR trial update, case presentation, and of course, this whole field of mitral is evolving since the data of the co-op trial and what to do. All right, Ani, sorry for late, very late actually.
It's okay.
But those who are here, they're still standing. And purpose always has been ours. As you saw that in CCC live cases also, we do right from the beginning to end. We don't do offline and then show. But that's not the purpose. Purpose was the struggle. Some cases and go through it. Same thing, like we could have cut down that core valve case doing the peripheral intervention beforehand and ready to just deploy the valve taking 2 minutes. But no, the whole case discussion was. With that note, Ani, yours.
Thank you. So I'm a cardiac surgeon, and Dr. Sharma asked me to show a case of a transcatheter mitral valve replacement. So there are several devices used for transcatheter mitral valve replacement. The one that we use at Mount Sinai is the Medtronic Intrepid valve, which is a transapically delivered valve. It's a porcine valve mounted on a nitinol stent, expanded into the valve, and we were involved in the Apollo trial, which is a clinical trial, which I'll go through. But I'm going to show you a case which we did in the pilot study which preceded that trial. So this was a 77-year-old female who had severe symptoms of congestive heart failure, multiple hospitalizations. She had had 2 prior operations, a bypass operation and an aortic valve replacement. So she also had peripheral vascular disease, some chronic obstructive airways disease, a previous stroke, and atrial fibrillation. So this is a baseline echocardiogram. She had a severe mitral valve regurgitation with a 3B mechanism secondary to ventricular dysfunction and remodeling. Her left ventricular ejection fraction was about 25%. She did have a coronary angiogram which showed that she had patent grafts to her left anterior descending and circumflex system. Left anterior descending and right coronary system. So she had a right heart catheterization, and as you can see, she had quite elevated fill-in pressures compatible with the known diagnosis. She had a bit of ascending aortic calcification, and she had some vascular disease, including an occluded celiac artery. So she was initially referred for mitral valve repair and was declined because of prohibitive risk. It was felt that with her low ejection fraction, and this was going to be the 3rd redo, that her survival rate probability was moderate at best, but probably low. So we enrolled her in the Intrepid global pilot study of this transcatheter mitral valve device. So as part of the planning for any transcatheter mitral valve replacement, the anatomical screening is key, because with the mitral valve there's a high risk of obstructing the left ventricular outflow tract, and also at least currently with the Apollo valve, there are just 3 sizes, and not all patients will fit into that size, into the size limits. Mainly because you have to oversize the valve for it to fit in. It has to be oversized and expand into the space. And also there has to be sufficient compression on the nitinol's frame, otherwise it will embolize. So the CT scan is the key to sizing, and this patient had quite a good sizing for a 43 valve, and also a patent left ventricular outflow tract. So the other considerations are the apex. So we make sure that the apex of the heart doesn't have any thrombus, and is of sufficient quality. Although she had a thin apex, it was thin because it was aneurysmal and scarred, and that will be good for surgeons to suture to, so that it didn't concern us. She had a previous aortic bioprosthesis, and the imaging showed the mitral prosthesis would be clear from the aortic prosthesis. So for all these patients, we admit them to hospital about 3-4 days prior to surgery to optimize them. We usually give them inotropes. We diurese them quite heavily, give them nutrition, sometimes supplemental nutrition, and physical rehabilitation. So we usually take a few days to get them ready. And often we see, as in this case, that the regurgitation is actually often gets less when you optimize the patients. So just taking you to the procedure, it's an echo-guided procedure. So the surgeons, we do a transapical access through the appropriate intercostal space, and it's guided by 3D, by both 2D and 3D echocardiography done transoesophageally. And we usually beforehand identify the landmarks to which we'll deploy the valve, which you see on the still image on the lower right-hand side. So the first step, once we've done the thoracotomy, we place a sheath in the ventricle. So that's usually straightforward, the same as we would do for a transapical procedure, for the transapical aortic valve procedure. And then we advance the delivery catheter under ultrasound control through the mitral valve. So we use an X-plane view, and then we always make sure that we can see the catheter and it's always central. Otherwise, there's a risk of perforating either the mitral valve leaflets or the aortic valve leaflets at that time. And then once we've done that, we advance the catheter into the left atrium. So the catheter is now in the left atrium, and we confirm that on the 3D view and move the catheter in all 4 dimensions to make sure it's not held by any chordae. And then the next step is to partially release the device. So we just slightly release the device so the brim expands. And then that will allow us to position the brim before we do the final deployment. So under a period of rapid pacing, we then position the brim. So we've already identified the landmarks where we think we need to place the valve, and usually we work this out relative to fixed landmarks like the coronary sinus or the aortic valve, and then we position it where we think we had identified previously to position it. And then we stop the pacing, and the next step, we're ready to deploy, and then we pace again, and then we deploy the valve fully. And the valve, once deployed, cannot be retrieved. So this is a point of no return, and the valve is deployed. And then once that's done, we take the catheter out and repair the apex of the heart. And usually works very well. You can see there's absolutely no regurgitation, and the left atrial pressure comes down straight away. No gradient across the LV outflow tract. So the main risk of this procedure, because the patient's anterior mitral leaflet is left in situ, is that the anterior mitral leaflet or the valve prosthesis could obstruct the outflow. And this is open. These patients usually have a stormy post-operative course. They're usually very sick. Most of them have functional regurgitation, usually need to be in intensive care for a few days, on inotropes for a week or 2. Often in hospital for 2 to 3 weeks. This patient was discharged 3 weeks after surgery. She did well for several months, but unfortunately she eventually died of renal failure. She did have renal failure after the procedure, was on hemofiltration. It recovered, but some months after she got renal failure again, ended up on dialysis, and she passed away. So what we have now that we're recruiting patients is the Apollo trial for this valve. It's a 2-arm trial. You have a randomized cohort and a single-arm cohort. Randomized cohort is for patients who are candidates for biological surgical valve replacement, and they're randomized either to get a surgical valve or a catheter valve. Patients who are not surgical candidates can go into the single-arm cohort, and the primary outcome is all-cause mortality, stroke, reoperation, and cardiovascular hospitalizations within 1 year. The trial is, the principal investigators are Dr. Leon, who was here today, and Dr. Adams. And as I said, there's a randomized arm and a single arm. The key inclusion criteria would be any patient with severe mitral valve regurgitation. And the main exclusion criteria that we've encountered in screening patients are anatomical considerations. So a lot of patients, you won't be able to get them in the trial. It's usually because of either the left ventricular outflow tract is too small, or we don't have the appropriate valve size, but there are several inclusion and exclusions. If you want to know more about the trial, you can go to the clinicaltrials.gov website. There are 41 centers that are currently enrolling, 4 of them in the New York area, but they're all over the country. And I think if you have any patients with severe mitral regurgitation who are high-risk patients for surgery, certainly those who can't have surgery you can consider for this trial, and those who can, you should also consider in the randomized arm. Thank you very much.